Good morning and good afternoon. We continue with part 3 of the series of lectures in pathology of the heart. For today's lecture, our topic will include congenital heart disease, studying its various forms, etiology, etiopathogenesis, morphological features, and clinical presentation. A formative exam will follow this lecture. Again, this is your faculty lecturer for cardiovascular module, Dr. Socorro Crucianes, Professor of the Department of Pathology. To start off, let us begin with an important message left to us by a Chinese Confucian philosopher, Mencius, thousands of years ago, which up to this day is still relevant and true. He said, "Great is the human who has not lost his childhood heart. The heart that loves is always young." Remember, please read your book. A quote from your favorite doctor, Dr. Seuss. He said, "You can find magic wherever you look." Sit back and relax. All you need is a book. The topic outline is listed for today's lecture, and it is listed as follows. These are the learning objectives we will accomplish in today's lecture. In order to understand the shunting and obstructive anomalies brought about by the congenital heart disease, it is important to briefly review the normal flow of blood from the venous circulation as it enters the vena cava to the right atrium and exiting to the heart from the left ventricle via the aortic valve to the aorta and systemic circulation. This is the normal pathway. Congenital heart disease refers to structural abnormalities of the heart or the great vessels that are present at birth due to faulty embryogenesis, usually during the first trimester between the gestational ages, weeks 3 to 8, when the major heart and the great vessels are formed. The most severe abnormalities are incompatible with intrauterine survival, and significant heart malformations are common among premature infant and stillborns. In 27, the incidence rate of congenital heart disease was 17.9 per 1,000 worldwide, with slight higher rates among males compared to females. Ventricular septal defect and atrial septal defect were the most common congenital heart disease. The global birth prevalence of congenital heart disease is 9 per 1,000, and reported death of 261,000 were reported globally. With ongoing and improving technology and surgical interventions, the mortality rate has steadily declined in the past 2 decades. Many have benefited from surgical advances that increasingly permit early repair and structural defects. The clinical presentations of patients with congenital heart disease will depend on the underlying nature of the defect, the size and extent of the malformation, and the age onset of the symptoms. Some patients may be asymptomatic, or others may have catastrophic clinical course with heart failure, hypotension to shock. Patients with congenital heart failure may present with any of these symptoms. They may present with murmur, cyanosis, failure to thrive, dyspnea, tachypnea, edema, clubbing of the digits, which refers to distal blunting and enlargement of the tips of the fingers and toes, or polycythemia, meaning high hemoglobin levels, and dysmorphic features that may indicate an underlying more serious genetic disease complex. Expected long-term complications include congestive heart failure, onset of pulmonary hypertension, and infective endocarditis. Echocardiography and cardiac catheterization now permit a detailed understanding of disordered anatomy before the cardiac surgery. This table lists the different congenital heart disease and the incidence rate per million live births and relative frequencies. The top three most common are the ventricular septal defect, atrial septal defect, and pulmonary stenosis. Tricuspid atresia is the least common with a frequency of 1%. This table lists the different types of congenital heart disease with their respective incidence rates and frequencies. Sporadic genetic abnormalities are the major known causes of congenital heart disease. They can take the form of a single gene mutations, small chromosomal losses, and additions or deletions of whole chromosomes, leading to trisomies and monosomies. Most patients have no identifiable genetic risk, and even in those that do, the nature and severity of the defect is highly variable. Thus, environmental factors alone or in combination with genetic factors are also increasingly implicated in congenital heart disease. There are other important etiologic factors associated with congenital heart disease. Some of these are classified broadly as environmental factors, and others are maternal factors where the child is exposed in utero. Environmental factors alone or in combination with genetic factors are also increasingly implicated in congenital heart disease. Exposure to organic solvents during pregnancy causes transposition of great vessels, tetralogy of Fallot, and pulmonary stenosis. Carbon monoxide exposure causes ventricular septal defect and tetralogy of Fallot. Maternal factors have also been implicated in the causation of congenital heart disease. Some examples include maternal rubella infection that causes PDA, pulmonary stenosis, atrial septal defect. The use of tricyclic antidepressants causes ventricular septal defect. Isotretinoin used for acne during pregnancy can cause ventricular septal defect and atrial septal defect. Some substance of abuse like alcohol, cocaine, and marijuana can cause ventricular septal defect. Smoking during pregnancy can cause VSD, ASD, and tetralogy of Fallot. The structural anomalies in congenital heart disease can be organized into three major categories according to the functional abnormalities. One is a left to right shunt anomaly producing acyanotic heart disease. The second are the right to left shunt anomalies producing cyanotic heart disease. And the third are various obstruction anomalies. A shunt is an abnormal communication between chambers. Examples are the ventricular septal defect and atrial septal defect, or between blood vessels. Examples are your patent ductus arteriosus. Abnormal channels permit blood flow across pressure gradients from different sides of the heart. A right to left shunt occurs when deoxygenated blood from the right side of the circulation flows directly into the left side of the heart, bypassing the pulmonary circulation, thereby resulting to hypoxemia and cyanosis. The poorly oxygenated venous blood shunts blood directly into the systemic arterial circulation, hence cyanosis is an important clinical presentation. On the other hand, a left to right shunt. The blood is diverted from the left side of the heart to the right side of the heart. For example, from the left ventricle, a high pressure chamber, to the right ventricle, which is a low pressure chamber. These are due to the natural flow of pressure gradient differentials. These are seen in cases of ventricular septal defect via a hole in the interventricular septum or atrial septal defect via a hole that is found in the atrial septum, and in patients with patent ductus arteriosus through persistent functional communications between the aorta and the pulmonary artery via a patent ductus arteriosus. The last are the obstructive anomalies, which are characterized by obstruction or blockage in the flow of the blood. A left to right shunt is a type of anomaly wherein the blood is diverted from the left side of the heart to the right side of the heart, hence the term left to right shunt. Due to differentials of pressure gradients, the natural flow of blood is from a higher pressure chamber of the left side of the heart to a lower pressure chamber in the right side of the heart. There are four congenital heart diseases producing a left to right shunt anomaly, and these are atrial septal defect, ventricular septal defect, patent ductus arteriosus, and atrioventricular septal defect. In atrial septal defect, there is a communication between the both atrial chambers, which allows blood to be diverted from the left atrium to the right atrium. In ventricular septal defect, there is a communication between two ventricular chambers which allows blood to be shunted or diverted from the left side of the heart to the right side of the heart. The communication between these two chambers are due to pressure or holes or openings. In patent ductus arteriosus, there is communication between two great vessels, the aorta and the pulmonary artery, through a persistent and functioning ductus arteriosus. An atrial septal defect is a congenital heart malformation characterized by a hole or a defect in the wall of the septum that divides the left and right side of the atrial chamber. A free communication allows blood to be shunted from the left atrial chamber to the right side of the atrium, leading to left to right shunting anomaly. The left to right shunting anomaly produces increased volume of blood flowing to the right atrium, resulting to right atrial volume overload. Depending on the size of the defect and associated anomalies, this can result in a spectrum of disease ranging from no significant cardiac sequelae to right-sided volume overload. There are some complications associated with this. In the end, are pulmonary hypertension and even atrial arrhythmias. At birth, the babies with atrial septal defects are acyanotic. Atrial septal defects make up approximately 10% of all congenital abnormalities of the heart. They are often asymptomatic early at birth and during childhood, but may become progressively symptomatic towards the third and fourth decade, often presenting with signs of right ventricular failure. Between the fourth and seventh week of fetal life, two distinct flaps of tissues develop to divide the common cavity into left atrium and right atrium. The first is the septum primum, and the second is the septum secundum, which grows upwards from the atrioventricular ring. In fetal life, this acts as a flap valve, allowing blood entering from the right atrium to flow directly into the left atrium. When the pulmonary circulation is established, it closes, and in most cases, the two layers of the flap fuse together. In many children, these flaps do not fuse and form a defect or an opening known as patent foramen ovale. A defect in this area is the usual form of atrial septal defect. Less common types of atrial septal defects are related to defects that are found low in the interatrial septum close to the atrioventricular ring, and this may be associated with abnormalities of the mitral valve. Other uncommon types of ASD are associated with defects in the development of the pulmonary veins or in the coronary sinuses. This is a schematic diagram of atrial septal defect. The primary defect is the presence of a hole or a gap or a defect in the atrial septum which allows free communication between the left and the right atrium. The left atrium has a higher pressure in contrast to the right atrium, which has a lower pressure. The pressure gradient difference allows blood to be shunted from the left atrial chamber to the right side of the atrium. leading to a left to right shunting anomaly. The left to right atrial shunt produces increased volume of flow of blood to the right atrium, resulting to right atrial volume overload. The adaptive responses to this great volume of blood flow in the right atrium is right atrial enlargement and dilatation, which leads to greater blood flow and volume overload in the right ventricle. A diastolic murmur may occur corresponding to abnormal heart sounds due to increased blood flow across the pulmonary valves and tricuspid valves. The morphologic effects of atrial septal defect then includes right atrial dilatation and right ventricular hypertrophy. Patients do not manifest cyanosis early because the blood that is shunted is largely oxygenated, and the blood to the right chamber of the heart consists of an admixture of deoxygenated blood from the venous circulation and oxygenated blood coming from the shunted left atrium. Over time, because of the increased blood flow to the right side of the heart, the lungs produces increased pulmonary pressure leading to pulmonary hypertension. This can develop right heart enlargement and eventually pulmonary hypertension. When this pulmonary hypertension is severe enough and the pressure gradient overcomes the pressure in the right ventricle, the direction of the shunt reverses to right to left, leading to cyanosis and causing Eisenmenger syndrome. There are three types of atrial septal defect. The first is the secundum atrial septal defect. The second is the primum type of ASD, and the third is the sinus venosus type of atrial septal defect. The secundum ASD represents 90% of atrial septal defect, with a hole located in the region of the foramen magnum. The second, primum ASD, represents 10% of the atrial septal defect, where the defect is found low-lying, located near the atrioventricular valve. These are associated with structural abnormalities of the mitral valve. The third are your sinus venosus type of ASD, which is a rare type of ASD, and the defect is high in the region of the entrance of the superior vena cava. An atrial septal defect of the secundum type is relatively common, representing 90% of atrial septal defect. It occurs from the failure of the septum secundum to develop, and this results in a communication between the left and the right atrium, directly causing a left to right shunt. This results to volume overload on the right side of the heart and increased blood flow to the lungs. The septum secundum is a membranous ingrowth in the middle portion of the atrial septum that covers the ostium secundum. The ostium literally means a hole in the septum secundum. It leaves only a small channel called the foramen ovale that is continuous with the ostium secundum, and the foramen ovale ostium secundum permits the continued right to left shunting of blood during intrauterine development. The flap of the septum secundum tissue opens and closes in response to pressure gradient between the left and right atria. The valve opens only when the pressure is greater in the right atrium. In the fetal life, the lungs are non-functional, and the pressure in the pulmonary circulation is greater than that of the systemic circulation. Thus, the right atrium is under a higher pressure than the left atrium, and the valve of the foramen ovale is normally opened intrauterine. At birth, with lung expansion, the pulmonary vascular pressure drops, and the right atrial pressures fall below that of those in the left atrium. As a result, the valve of the foramen ovale and usually becomes permanently sealed and closed before adulthood. When this persists, atrial septal defect can develop. The diagnosis of atrial septal defect is made on transthoracic echocardiography. The gross picture that is seen is an example of a large hole or opening in the septum secundum, seen from the right side of the opened right atrium. As a consequence of the increased blood flow and volume overload on the right atrium is enlarged and dilated. The foramen ovale is a tunnel-like space between the overlying septum secundum and septum primum. It closes in 75% of people at birth when the septum primum and secundum fuse. The foramen ovale closes permanently in approximately 20% of people by 2 years of age. In the remaining 20%, the unsealed flap can open if the right-sided pressures become elevated. In utero, the foramen ovale is necessary for the flow of blood across the fetal atrial septum. Once the pulmonary circulation is established after birth, the left atrial pressure increases, allowing functional closure of the foramen ovale. This is followed by anatomical closure of the septum primum and septum secundum by the age of 1 year, and in approximately 25% of people, a persistent foramen ovale or a patent foramen ovale can persist into the adulthood. This is a large secundum type of atrial septal defect. The location of the hole is noted in the middle portion of the region of the foramen ovale. Note the dilatation of the right atrium. This is a picture of a large secundum type of atrial septal defect with a hole opening in the middle portion of the atrial septum. There is associated right atrial dilatation due to volume overload on the right side of the heart. There are complications that can occur with atrial septal defect. A paradoxical thromboembolism can be seen here, in the black arrow, in which a phlebothrombus originating from the venous circulation travels and reaches the right side of the heart and can gain entry into the systemic arterial circulation via a patent septal defect. Take note of the arrow of the phlebothrombus. This is a picture of a patent foramen ovale seen coming from the right atrium. Patency is determined by probing that is seen on the left atrium. Primum ASD accounts for 5% of atrial septal defect. The defect is low-lying and occurs adjacent to the atrioventricular valve and are often associated with atrial valve abnormalities and ventricular septal defect. The septum primum is a crescent-shaped, membranous ingrowth that sits posteriorly between the right and left atria and partially separates this right and left atrial chamber. The septum has a transient small anterior opening called the ostium primum, which allows movement of blood from the left to right atrium during fetal development. Persistence of the ostium primum leads to primum type of atrial septal defect. A sinus venosus atrial septal defect is a type of atrial septal defect primarily associated with the sinus venosus. This typical malformation is an interatrial communication caused by a deficiency of the common wall between the superior vena cava and the right-sided pulmonary veins. They represent 5% of the atrial septal defect. They occur near the superior vena cava or the inferior vena cava, with the former being more common. They are associated with the total anomalous pulmonary venous return, which produces additional left to right shunting anomaly. The clinical features of atrial septal defect, they are usually asymptomatic in the first 2 decades of life. Symptoms begin to occur in the 3rd and 4th decade of life, and these are largely due to the development of pulmonary hypertension. The signs and symptoms include dyspnea, fatigue, edema, palpitations, arrhythmia, shortness of breath, and a murmur. The murmur is caused by high blood flow towards the pulmonary valves. The complications associated with atrial septal defect include increased risk of stroke formation, pulmonary hypertension, and the development of an Eisenmenger major complex that produce a reversal of the shunt. Long-term morphologic and clinical effects of atrial septal defect include the following: right atrial hypertrophy and enlargement, right ventricular hypertrophy and enlargement. Both right atrial and right ventricular hypertrophy are reflections of adaptive responses to the increased volume overload on the right side of the heart. The increased pulmonary blood flow in the lung eventually will produce pulmonary hypertension. Clinically, diastolic murmurs can be elicited as a result of increased blood flow along the pulmonary valve. Ultimately, right-sided heart failure can occur among these patients. Ventricular septal defects is the most common form of congenital heart defect, accounting for 40% of cases in infants. A minority, about 30%, occur as an isolated anomaly, and majority are complex with other congenital heart defects like tetralogy of Fallot. They are classified as left to right shunt anomaly and are acyanotic at birth. Small defects in the muscular wall may spontaneously close in 50% of cases as the patient ages. Surgical closure is an indication for larger membranous and muscular defects. The size and the site of the ventricular defect determines the extent of the shunt. In some cases, defects in the membranous septum are also associated with valvular abnormalities, particularly aortic incompetence, and this influences the clinical presentation. This is a schematic representation of the hemodynamic changes in ventricular septal defect. The structural abnormality involves the presence of a defect or a hole in the interventricular septum that allows communication between the left and the right ventricles. It produces a left to right shunt since the unidirectional flow of blood is from the left side with a high pressure gradient to the right side with a low pressure chamber gradient. This allows mixing of oxygenated and deoxygenated blood, so patients with VSD have no cyanosis. The increased blood flow from left ventricle to right ventricle produces volume overload to the right side of the heart and to the lungs. Long-term effect produces right ventricular hypertrophy, right atrial dilatation, and pulmonary hypertension. The ventricular septum consists of an inferior muscular and a superior membranous portion. Defects in the ventricular septum are classified according to the location of the defect, and these are membranous VSD, infundibular VSD, and muscular VSD. About 90% occur in the region of the membranous interventricular septum and are called membranous VSD. Majority measure about 2 to 3 centimeter in diameter. The remaining 10% occur below the pulmonary valve and are known as infundibular VSD. Ventricular septal defects that are located within the muscular septum are called muscular VSD. 50% of muscular VSD generally close spontaneously. These are gross pictures of membranous type of ventricular septal defect. The defect or the hole has a high location in the membranous portion of the ventricular septum. It is the most common type of VSD. The picture taken is from the right ventricle, and the right ventricular wall appears thick and hypertrophic in response to the volume overload. The hole or the defect is pointed in the black arrow. This is a picture of a muscular ventricular septal defect. The defect is noted in the lower muscular portion of the ventricular septum. 50% of these cases regress spontaneously. Ventricular septal defect is usually symptomless and acyanotic at birth. The symptoms appear earlier in the pediatric age group in contrast with atrial septal defect, and they are associated with other congenital cardiac anomalies such as tetralogy of Fallot. Only 20 to 30% are isolated. The functional consequences and clinical manifestations are dependent on the size of the defect and associated congenital malformations. 50% of small muscular VSDs close spontaneously. Large defects are usually membranous or infundibular and have earlier right ventricular hypertrophy and pulmonary hypertension. Signs and symptoms may be tachypnea, dyspnea, fatigue, and a failure to thrive. A large pansystolic murmur with a thrill is a diagnostic physical examination findings. Larger defects may eventually be associated with pulmonary hypertension due to increased blood flow leading to Eisenmenger complex. The most important clinical complications of ventricular septal defect is congestive heart failure and infective endocarditis. The third type of left to right shunt anomaly is the atrioventricular septal defect. Atrioventricular septal defect is sometimes called endocardial cushion defect or atrioventricular canal defect. AVSDs are anatomic defects that arise from the faulty development of the embryonic endocardial cushion, which represents the primordia of the atrioventricular septum and the atrioventricular valves. This results to an incomplete closure of the AV septum and inadequate formation of the tricuspid and the mitral valves. The primary defect is the failure of the formation of that part of the heart that arises from the embryonic structures called endocardial cushions. The endocardial cushions are responsible for separating the central part of the heart near the tricuspid and mitral valves, which separates the atria from the ventricles. The structures that develop from the endocardial cushions include the lower part of the atrial septum, the higher portion of the ventricular septum, and the atrioventricular valves. The endocardial cushions also complete the separation of the mitral and tricuspid valves by dividing the single valve between the embryonic atrium and ventricles. The atrioventricular septal defect may involve failure formation of any of these structures. As a result of the abnormal passageway between the two sides of the heart, blood from both sides mixes and too much blood circulates back to the lungs before it travels to the body. They may eventually result in the formation of a pulmonary hypertension leading to Eisenmenger complex and cyanosis. They account for about 5% of all congenital heart diseases and are most common in infants with Down syndrome. About 15 to 20% of newborns have Down syndromes with atrioventricular septal defect. There are two types of atrioventricular septal defect, and they can be classified into partial AVSD and complete AVSD. A partial or incomplete AVSD is one in which the part of the ventricular septum formed by the endocardial cushion has filled in, either by tissue from the atrioventricular valves or directly from the endocardial cushion tissue, and the tricuspid and mitral valves are divided into two distinct valves. The defect is therefore primarily in the atrial septum and the mitral valve. This type of atrial septal defect produces the ostium primum type of atrial septal defect and is usually complex or associated with a cleft in the mitral valve that may cause the valve to leak. The second is the complete AVSD. It is one in which there are defects in all the structures formed around the endocardial cushions. Therefore, these defects have atrial septal defect, ventricular septal defect, and defects in the atrioventricular valve. So therefore, all four chambers are freely communicating with each other. This is the schematic diagram of an atrioventricular septal defect. The main abnormality is in the region of the endocardial cushion. This is a picture of a complete AVSD where the defects that are present are the presence of an atrial septal defect, the presence of a ventricular septal defect, and abnormalities in the anterior leaflet of the mitral valve. These structural abnormalities lead to a much bigger left-to-right shunting anomaly with all four chambers freely communicating with each other. There is greater volume of blood shunted to the right side, thus producing a much bigger magnitude of volume overload, leading to earlier right ventricular heart hypertrophy and more pronounced right atrial dilatation and increased volume of pulmonary blood flow. The pulmonary hypertension and the Eisenmenger complex can occur much earlier. Patients will have more symptoms. This is a gross picture of an atrioventricular septal defect. The view is on the atrial level, looking through the mitral valve. Note that there is no atrial septum that separates the left and right atrium, and the mitral valve appear clefted and incompetent. The ventricular septal defect is not shown in this picture. This results to a situation in which all four chambers are freely communicating with each other. The other type of left to right shunting anomaly is the patent ductus arteriosus. In the normal embryonic development, the ductus arteriosus arises from the pulmonary artery and joins the aorta just distal to the origin of the left subclavian artery. During the intrauterine life, it permits blood flow from the pulmonary artery to the aorta, thereby bypassing the unoxygenated lungs. Shortly after birth in healthy-term infants, the ductus constricts and is functionally closed after 1 to 2 days. This occurs in response to increased oxygen tension, decreased pulmonary vascular resistance, and a declining local level of prostaglandin E2. Although some occur in association with heart defects, majority of these are related to an isolated anomaly. A persistent ductus arteriosus is diagnosed when the ductus arteriosus fails to close after 72 hours. A patent ductus allows blood to be shunted from the aorta, which is the left side of the heart, to the right side of the venous system, in the direction of the pulmonary artery. Patent ductus arteriosus increases the pulmonary blood flow and left atrium, and the ventricular volume likewise increase. PDAs account for about 7% of cases of congenital heart disease, and 90% of these are isolated defects. 10% of cases are associated with other types of congenital heart defects like VSD, coarctation of the aorta, pulmonic and aortic valvular stenosis. PDA produces a characteristic continuous murmur, which we call machinery type of murmur. Physiologic consequences depend on the ductal size. A small duct usually causes minimal symptoms, whereas a large ductus causes a large left to right shunt. Over time, again, the large shunt results in left ventricular enlargement, pulmonary artery hypertension, and elevated vascular resistance, leading to an Eisenmenger syndrome. This is a diagrammatic picture showing the salient hemodynamic changes in patent ductus arteriosus. The basic defect is the persistence of the ductus arteriosus, which normally closes within 72 days after birth. Persistence of these fetal vessels allows the communication between the aorta with the pulmonary artery. There will be a greater volume of oxygenated and deoxygenated mixture of blood going to the pulmonary artery, producing volume overload in the right ventricle and increased pulmonary blood flow. The morphologic effects will include right ventricular hypertrophy, right atrial dilatation, and long-standing pulmonary hypertension. This is the gross picture of the heart showing patent ductus arteriosus, characterized by a persistent communication between the descending thoracic aorta and the pulmonary artery that results from failure of normal physiologic closure of the fetal ductus arteriosus. The picture on the left shows a communication between the aorta and the pulmonary artery with the presence of a metal probe. These are seen in the blue arrow. On the right, the short segment of the ductus arteriosus is identified that connects the aorta with the pulmonary artery, and this is highlighted with the blue arrow. The clinical features of patients with patent ductus arteriosus depend on the size of the ductus and how much blood flow it carries. The patients are acyanotic at birth and when symptomatic may have tachypnea, dyspnea, fatigue, and failure to thrive. Complications include congestive heart failure, endocarditis, pulmonary hypertension. Right to left shunt anomalies are a group of congenital heart diseases that cause cyanosis early in the postnatal life. Hence, they're also called cyanotic congenital heart disease. There are 5 congenital heart diseases belonging to this category, and they are tetralogy of Fallot, which is the most common, the transposition of the great vessels, truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return. Early cyanosis is a symptom of right to left shunt. A right to left shunt results in a decreased blood flow through the pulmonary system, leading to decreased blood oxygen levels and hypoxemia. Hypoxemia results and manifests as cyanosis, causing blue babies at birth. Tetralogy of Fallot is a type of cyanotic heart disease producing a right to left shunting anomaly. They manifest with early cyanosis at birth, and they are the most common form of a right to left shunt heart disease. There are 4 cardinal features of the tetralogy of Fallot. They are 1. Ventricular septal defect, 2. An obstruction of the right ventricular outflow tract due to the presence of a subpulmonic stenosis, 3. An aorta that overrides the ventricular septal defect, and the presence of right ventricular hypertrophy. All of these features result embryologically from anterosuperior displacement of the infundibular septum. During fetal life, the infundibulum do not rotate to its normal anatomic location with the developmental arrest of the septum at the mid portion. This produces an aorta that is located beneath the overriding interventricular septum. There is concomitant failure in the formation of the membranous septum leading to a defect in the ventricular septum or a VSD. In the infundibulum, the pulmonary artery development is affected and is wedged and pressed, producing a subaortic stenosis. As a result of the greater workload against an obstructed pulmonary outflow tract, the right ventricle adopts by right ventricular hypertrophy. As a result of these anatomic defects, blood flow is shunted from the right side to the left side via an opening of the ventricular septal defect, and also due to the presence of an outflow tract obstruction at the level of the stenotic pulmonary artery. The most important determinant of the severity and the clinical consequence of the tetralogy of Fallot is the degree of the right ventricular outflow tract obstruction due to pulmonary stenosis. With a lesser obstruction, blood is shunted from left to right and permitted to preferentially enter the pulmonary circulation, allowing for oxygenation. With a greater degree of obstruction, however, blood is forced in the opposite direction, away from the pulmonary circuit, leftward towards the ventricular septal defect. Hence, the flow of blood is from right to left side of the heart. This is a schematic diagram of the tetralogy of Fallot with the four elements of the tetralogy: a pulmonary stenosis, a ventricular septal defect, an aorta that overrides over the ventricular septal defect, and right ventricular hypertrophy. Central to the lesion is the presence of pulmonary stenosis, which produces an outflow tract obstruction, impeding blood flow to the lungs and preventing oxygenation. Hence, patients are cyanotic. Blood entering the heart from the venous circulation goes to the right atrium, proceeding to the right ventricle, and blood gets to be shunted from right ventricle direct to the left ventricle via an interventricular septal defect, bypassing the lungs, preventing oxygenation. This is due to the presence of the pulmonary stenosis. The right to left shunting anomaly is accompanied by cyanosis that becomes manifest early at birth. The right ventricular hypertrophies come in order to overcome the pressure gradient against the obstructed pulmonary outflow tract. The morphologic features of tetralogy of Fallot include a heart that typically becomes enlarged and is classically boot-shaped due to the marked right ventricular hypertrophy. The X-ray is shown on the upper right with the corresponding gross appearance showing the typical boot-shaped deformity. There is a large ventricular septal defect, and there is displacement of the aorta and the atrial valves at the superior border, thereby overriding the defect. The aortic valve is enlarged and appears to arise from both the left and the right ventricles instead of the left ventricle as in the normal heart. The obstruction to right ventricular outflow is most often due to the narrowing of the infundibulum, which we call subaortic stenosis, but can also be accompanied by pulmonary valvular stenosis. Sometimes a complete atresia of the pulmonary valve can be identified. Other accompanying lesions may be observed. The presence of a patent ductus arteriosus may be necessary for survival. Aortic valve insufficiency or an atrial septal defect may also be present. The clinical features and survival of tetralogy of Fallot depend on the severity of the subpulmonic stenosis. If the subpulmonic stenosis is mild, the abnormality resembles an isolated ventricular septal defect, and the shunt may be a left to right shunt without cyanosis. This is called the pink tetralogy. With a more severe pulmonary stenosis and right ventricular outflow tract obstruction, right-sided pressures approach or exceed left-sided pressures, and the left-to-right shunting develops, producing cyanosis. And this is what we see in classic tetralogy of Fallot. Most infants with tetralogy of Fallot are cyanotic at birth and soon thereafter. The more severe the pulmonic stenosis, the more hypoplastic are the pulmonary arteries and the larger is the overriding aorta. The clinical features are often characteristic. The shunting of oxygen-poor blood results in the reduction in the arterial oxygen saturation so that the babies appear cyanotic or blue. The systolic murmurs are present and can result either from a ventricular septal defect or from the pulmonary stenosis. As in all hypoxic patients, the hemoglobin concentration is increased, resulting to polycythemia. Some children with tetralogy of Fallot sometimes adopt a characteristic squatting posture with a sit in a knee chest position. This may be an attempt to increase the venous return from the lower limbs. Rapid breathing in response to low oxygen tensions are seen. Complications of tetralogy of Fallot may include right ventricular failure, infective endocarditis. Another type of right to left shunt and cyanotic heart disease is the transposition of the great vessels. Transposition of the great arteries or great vessels produce a ventriculo-arterial discordance. In the more common variant, the aorta arises from the right ventricle and the pulmonary artery emanates from the left ventricle. This allows blood from the venous circulation to be shunted directly into the systemic circulation via the malpositioned aorta that arises in the right ventricle. This leads to a right to left shunt anomaly. Cyanosis develops early because blood fails to reach the pulmonary circulation. This is incompatible with life. Associated lesions like ventricular septal defect, patent ductus arteriosus may be life-saving, as this allows blood to enter the pulmonary circulation for oxygenation. Other associated lesions may be right ventricular hypertrophy and left ventricular hypoplasia, where the left ventricle becomes thin-walled and atrophic as it supports the low-resistance pulmonary circulation. Without an arterial switch surgery, most patients die within days and months. This is a schematic picture of transposition of great vessels. The aorta originates from the right ventricle, and the pulmonary artery arises from the left ventricle. There is switching or transpositioning of the normal position of the great vessels. This leads to a right to left shunt and cyanosis. In the left is a transposition of great vessel with associated ventricular septal defect, which allows the blood to go into the pulmonary circulation. On the right side is a transposition of great vessels without the ventricular septal defect. The venous blood is directly shunted into the systemic circulation via the right ventricle and the aorta because of the malpositioned aorta. This is incompatible with life. This is a gross picture of transposition of great vessels. Notice that the great vessels, aorta, and the pulmonary artery are malpositioned and switched, with the aorta emanating from the right side of the heart and the pulmonary artery emanating from the left ventricle. The right ventricle becomes hypertrophic, which appears on the yellow arrow, as it needs a higher workload to propel blood to the systemic circulation. The schematic diagram is seen on the left. Another type of right to left shunting anomaly is called truncus arteriosus. Truncus arteriosus is an uncommon congenital cardiovascular anomaly that is characterized by a single arterial trunk arising from the normal formed ventricles by means of a single semilunar valve known as a truncal valve. This is caused by the failure of separation of the great vessels, aorta, and the pulmonary artery, and they remain as a single large vessel known as truncus arteriosus. This great vessel usually has one large valve, which may have 2 to 5 leaflets. Usually this great vessel sits over the left and right ventricle. An associated ventricular septal defect can be seen. This is a composite gross and schematic picture of truncus arteriosus. In truncus arteriosus, there is a failure of separation of the embryogenic great vessels into the aorta and the pulmonary artery. There is a single artery that originates from the heart above a ventricular septal defect. This single artery is known as truncus arteriosus. The gross picture shows an opened right ventricle with a dilated truncus arteriosus seen in the blue arrow. The aorta, the red arrow, and the pulmonary artery, the yellow arrows, are seen, and they share one common outlet. A ventricular septal defect is noted and seen in the green arrow. A baby with truncus arteriosus usually presents with cyanosis in the first few days of life because of the excessive amount of blood flow to the lungs. Congestive heart failure develops very early. On chest x-ray, there is cardiomegaly. Tricuspid atresia is a form of congenital heart disease whereby there is a complete absence of the tricuspid valve. Therefore, there is an absence of right atrioventricular connection. This leads to a hypoplastic and undersized or absent right ventricle. It results embryologically from an equal division of the AV canal. Thus, the mitral valve is larger than normal and there is right ventricular underdevelopment and hypoplasia. Blood from the venous circulation can enter the right atrium, but because of the complete absence of the tricuspid valve, blood cannot enter the right ventricle. The blood can only enter the left side in the presence of an atrial septal defect. The circulation can be maintained by right to left shunting through an interatrial communication, either through an atrial septal defect or a patent foramen ovale. Cyanosis is present from birth and there is slightly high early mortality. An atrial septal defect must both be present to maintain blood flow from right to left to allow access to the lungs. Other findings may include a large mitral valve that is seen in the yellow arrow, an underdeveloped right ventricle that is seen in the blue arrow, and an atrial septal or a ventricular septal defect which are seen in the white arrows. Cyanosis is present from birth and there is a high early mortality. The signs and symptoms of tricuspid atresia depend on the presence and size of the ventricular septal defect and the relationship of the great arteries. The pulmonary veins are the four blood vessels, two on each side, that returns oxygen-rich blood from the lungs to the left atrium. Total anomalous pulmonary venous return, or TAPVR, is a rare congenital malformation in which all four pulmonary veins do not connect normally to the left atrium. Instead, the four pulmonary veins drain abnormally to the right atrium by way of an abnormal or anomalous connection. Some associated cardiac anomalies include atrial septal defect and patent ductus arteriosus. The morphological effects on the heart of a patient with TAPVR include right atrial dilatation, right ventricular hypertrophy, pulmonary trunk dilatation, and hypoplastic left atrium. Because of the abnormal pulmonary vein connections, the red pathway represented by oxygenated blood returning from the lung mixes with the blue, which represented by deoxygenated blood from the venous circulation. The left side of the heart are filled only by mixed blood shunting across the atrial septal defect. Because this blood is a mixture of oxygenated and deoxygenated blood, the overall oxygen content is decreased. This explains the cyanosis of patients with DAPRV. If the atrial septal defect is small or restricted to blood flow from the right atrium to the left atrium, then the volume of blood filling the left atrium and the left ventricle may be reduced and may lead to low cardiac output and shock. Congenital obstruction to blood flow can occur at the level of the heart valves or within the great vessels. Common examples include pulmonary valve stenosis or atresia, coarctation of the aorta, and aortic stenosis or atresia. Coarctation of the aorta is a congenital heart disease wherein there is a localized constriction or stricture in the segment of the aorta. This results to impedance to blood flow. The defect accounts for up to 5% of all forms of congenital cardiovascular diseases and is twice more common among males. There are two types of coarctation of the aorta. The first is infantile coarctation, and the second is the adult coarctation. In infantile coarctation, the coarctation occurs proximal to the patent ductus arteriosus, and patients are usually symptomatic early. In adult coarctation of the aorta, a ridge-like coaptation occurs at the level or after the patent ductus arteriosus. About 98% of coarctations are postductal or adult in nature, where the narrowing occurs distal to the ductus arteriosus. Coarctation of the aorta may occur as an isolated defect or in association with other various lesions, most of them associated with bicuspid aortic valve and ventricular septal defect. This is a schematic picture of a coarctation of the aorta showing a constricted segment of the aorta at the level of the ductus arteriosus. This is an adult type of coarctation of the aorta. A preductal coarctation is characterized by the circumferential narrowing of the aortic segment between the left subclavian artery and the ductus arteriosus. The ductus typically is patent and is the main source of unoxygenated blood that is delivered to the distal aorta. The pulmonary trunk is dilated due to the increased blood flow because the right side of the heart now perfuses the body distal to the narrowed segment. The right ventricle typically is hypertrophied. In the adult or postductal coarctation, the aorta is sharply constricted by a tissue ridge adjacent to the ductus arteriosus. The constricted segment is made up of smooth muscle and elastic fibers derived from the aortic media. Proximal to the coarctation, the aortic arch and its branches are dilated and the left ventricle is hypertrophied. This is a gross picture of the coarctation of the aorta with a segmental narrowing of the aorta that is seen in the blue arrow. There is dilatation of the ascending portion of the aorta and the major branch proximal to the coarctation, which is seen in the red arrow. The lower extremities are perfused predominantly by way of dilated tortuous collateral channels. The upper left picture is a cross-section of the narrowed segment of the coarctation of the aorta. These are gross pictures of coarctation of the aorta with narrowed segments of the aorta, which are seen in the yellow arrows. The signs and symptoms are largely dependent on the degree of constriction. If this is severe, symptoms develop soon after birth. If the coarctation is undetected or untreated, a collateral circulation develops to increase blood flow to the lower part of the body. The process involves branches of the intercostal arteries, which becomes dilated and tortuous. The most characteristic clinical finding is hypertension in the upper limbs with a much lower pressure in the distal portion of the coarctation. The femoral pulses are often reduced. The abnormal blood flow through the coarctation segment may produce a systolic murmur best heard in the posterior chest. Pulmonary stenosis and atresia is a relatively frequent malformation leading to obstruction at the level of the pulmonary valve. The obstruction may be mild to severe, and the lesions can also be isolated or part of a more complex anomaly, either tetralogy of Fallot or transposition of the great vessels. Right ventricular hypertrophy typically develops. With coexisting pulmonary stenosis, the pulmonary trunk is not dilated and may in fact be hypoplastic. When the valve is entirely atretic, there is no communication between the right ventricle and the lungs. In such cases, the anomaly is associated with a hypoplastic right ventricle, and an atrial septal defect may be necessary to reach blood from the right side to the lungs. Mild stenosis may be asymptomatic and compatible with long life, whereas symptomatic cases require surgical correction. When the right ventricle is severely hypoplastic, blood can be surgically routed directly from the vena cava to the pulmonary artery, bypassing the right side of the heart. This ends the discussion on part 2 of the pathology of the heart. The references are listed for your guidance, and please read your book. Thank you, good day, and be safe, everyone.